How's it going, guys? We have a difficult question for pulmonary slash micro. 39-year-old woman, 31 weeks gestation, 2-day history, fever, dry cough, emigrated from Bali to the United States 7 years ago. That's the USMLE's way of telling you she's unvaccinated. They'll do that frequently, immigrant status. Antenatal screening, she has not had. Antenatal and prenatal are the same thing, just means before birth. Febrile at 102, and then she has a chest x-ray showing a bilateral ground glass appearance. We don't expect you to be a radiology expert, but that's what we're looking at here. And then a DNA virus is suspected. So let's just whip through. Choice A, CMV, round fucking answer. CMV pneumonia is very high yield for USMLE, but they'll show you light microscopy of the intranuclear inclusions that look like owl eyes. And they'll give you a background of organ transplant recipient or blood transfusions, because CMV is the most common organism transmitted via organ transplants and blood transfusions. And of course, you treat CMV with ganciclovir. It's DNA polymerase inhibitor, causes chain termination, resistance, is altered or absent viral thymidine kinase. So in addition to basic HIV presentations, let's say, where you have blurry vision, CMV retinitis, odynophagia, CMV esophagitis, or bleeding per rectum, CMV colitis, you need to know about CMV pneumonia for USMLE. Choice A, wrong fucking answer. Choice B, EBV, wrong fucking answer, mononucleosis. So that's when you have a tetrad of absence of cough, number one. Number two, cervical lymphadenopathy. Number three, tonsillar exudates. Number four, febrile 38 or greater. That tetrad right there, those four findings, make it look bacterial. And it's often misdiagnosed as strep pyogenes, group A strep pharyngitis. So patients will have a negative rapid strep test because it's not a sensitive test to begin with. They'll have a throat culture, but while those results are pending, they'll be sent home on amoxicillin or penicillin, and they'll get a rash, because you need to know that if you have an EBV infection, you're given a beta-lactam, you can get a rash. It's weird, but you gotta know that for USMLE. So if a 6-year-old with a sore throat gets a rash to beta-lactam, it's probably beta-lactam allergy. If an 18-year-old gets a rash to beta-lactam, it's probably EBV, so you do a monospot test, aka heterophile antibody test. And you need to know that EBV specifically invades B cells. That's why there's increased risk of Hodgkin and non-Hodgkin lymphomas, which are almost always B cell in origin. But the atypical lymphocytes that you get in mononucleosis are specifically CD8 plus reactive T cells that are responding to those EBV infected B cells. So you also need to know that EBV can cause nasopharyngeal carcinoma. Wrong fucking answer. Choice C, germ measles, rubella, wrong fucking answer, it's an RNA virus. So, and choice D, rubella, which is regular measles, also fucking wrong, because that's also RNA virus. So both rubella, German measles, and rubella, regular measles, can present with a maculopapular rash head to toe. The difference you gotta know is that measles, rubella, you can get Koplik spots, the whitish lesions on the buccal mucosa. Rubella, German measles, you can get post-auricular / suboccipital lymphadenopathy. And cough cries of conjunctivitis is garbage for regular measles. You can see that in a myriad of infections that are viral. It's non-specific for viral infections, and students get questions wrong because they think that's measles. It's nonsense. Obviously, rubella also important just for pregnancy-related stuff, because if you have congenital rubella syndrome, that can cause patent ductus arteriosus. Wrong fucking answer. Choice C, varicella, correct answer. Varicella can cause increased risk of pneumonia in pregnant women. All right, and we gave you unvaccinated status here, and we eliminated to get there. So we're left with 3 DNA viruses, CMV, EBV, and varicella. And if you know the high yield presentations as far as what CMV, EBV relate to, and you say, well, varicella can be seen in pregnant women, it's what we're left with. Now, more 2CK step 3 stuff, but varicella, if a woman has exposure to it, active chickenpox while pregnant, and she's unvaccinated, she should have immunoglobulin, varicella immunoglobulin within 96 hours. If a pregnant woman gets chickenpox within 5 days of giving birth up to 2 days post-parturition, then you give varicella immunoglobulin to the neonate. Okay, if let's say the pregnant woman is vaccinated or had history of chickenpox, meaning she's immune, and then you've got the neonate, let's say he's in a cot in the ICU or wherever in the hospital, and there's some 6-year-old running around who's got chickenpox and the neonate's exposed, the answer is you don't have to give immunoglobulin to the neonate because of the IgG passive immunity from the mom. Okay, so there's some weird factoids you got to know regarding varicella. And obviously, varicella is the virus that causes shingles, which is aka herpes zoster. That'll confuse students. Herpes zoster is not the name of a virus. Herpes zoster is literally just another name for shingles caused by varicella zoster virus. Okay, and it's not going to. It's only about 50, maybe 2/3 of questions on USMLE will be your immunocompromised patient who's older. You can also get it in pediatrics. You can get pediatric shingles if they give you, let's say, a 3-year-old girl who has ALL and she had chemo or radiotherapy. You can get shingles as well, varicella. Correct answer. You know the deal. Until you make more content on my subscription. Appreciate your time. That's it.